Hello, and welcome to our listeners around the world. This is the JAMA Editor Summary, and today is Friday, February 14th, 2025. I'm JAMA Deputy Editor Dr. Linda Brubaker, sitting in for the JAMA Editor-in-Chief, Dr. Kirsten Bibbins-Domingo, and I'm joined today by Dr. Preeti Malani, JAMA Deputy Editor. Hi, Preeti. This week was busy at JAMA, and there's plenty of content. Let's get started with the research articles.
Hi, Linda. It's great to be joining you today. JAMA published a research article this week about healthcare spending that suggests that spending really varies across different U.S. counties. Dr. Dielman and colleagues conducted an observational study looking at healthcare spending and utilization from 2010 to 2019. They used insurance claims and facility records from over 3,000 U.S. counties and included Medicare, Medicaid, private insurance, and out-of-pocket payments. They included spending for 148 different health conditions. The authors reported that spending was greatest for type 2 diabetes. They also found that cross-county variation was driven mostly by variation in utilization rates. Dr. Gleed contributed an editorial that highlights how these findings emphasize geographic variation in health system utilization. She points out previous studies that also suggest healthcare differences based on geography and how this concept can shape future health policy. In a related JAMA author interview podcast, JAMA Associate Editor Dr. Karen Joint-Maddox delves into this topic further with corresponding author Dr. Joseph Dielman. Let's listen to a bit of their discussion.
For me, I think there's a couple of really interesting takeaways. The first is that the most variation, even though we see variation everywhere, the most variation is out-of-pocket spending and emergency department use. And this is, in many ways, resources that in many cases could be prevented or could be treated elsewhere in some cases. And so in some places, a lot of money is coming out of pocket and a lot of spending is happening in the emergency department. And asking the question, what can be done in those places to either help the patients out that are doing the spending and make sure that they have access to the insurance they need and that they have access to the preventative and primary care that they need that could maybe reduce some of that extra emergency department visits. I think the other is exactly what you're saying about Goldilocks and trying to find the space in between where there is enormous amount of spending and where there is very little spending, and asking, are there places that are doing it right? Are there places where the outcomes are optimal relative to the spending and the inputs as well? And I think that's future analysis that we're really excited to be able to dive into.
This week, JAMA also published a timely collection of content on reproductive health. Dr. Belinsky wrote an editorial for 2 of the reproductive health research articles, in which she reiterated the significant effects that state-level abortion bans have on birth rates and infant mortality, especially for vulnerable populations. She offers important considerations for advocating for a healthy population when abortion bans are in place. In one of these articles, Dr. Gamil and colleagues evaluated infant mortality in states with a complete or 6-week abortion ban in a cross-sectional study from 2012 through 2023. Compared to the pre-ban period, the authors reported a higher than expected infant mortality in states after the adoption of abortion bans. In the other article, Dr. Bell and colleagues investigated the effect of a complete or 6-week abortion ban on fertility rates. The authors report that fertility rates in states with abortion bans were higher than would have been expected without these policies. They also report findings of health disparity based on higher than expected differences for racially minoritized individuals, unmarried individuals, individuals younger than 35 years of age, Medicaid beneficiaries, and those individuals without college degrees, particularly in the southern states. Let's listen to editorialist Dr. Belinsky dive further into this research with JAMA Deputy Editor Dr. Tracy Liu.
I don't think we need to solve national disagreements about abortion in order to collectively agree to support children throughout the country. I don't think we need to resolve these contentious debates in order to figure out policies that can have positive outcomes for the people affected by changes in abortion laws. And so my hope is that even as people have divergent reactions to these findings, we can still find common ground to pursue policies that improve outcomes for women, children, and their families today.
And two related JAMA viewpoints focus on legislation and reproductive health. Dr. Ivy explains the impact of restrictive anti-abortion regulations, particularly in Texas. He provides specific examples of legislation and recent statistics and describes the uncertainty facing clinicians who are providing evidence-based reproductive health care. In a separate JAMA viewpoint, Dr. Tassett and colleagues call attention to Louisiana's legislative reclassification of medications commonly used for abortion care as controlled substances. The authors highlight the lack of evidence for this action and the burdens this legislation places on pharmacies, clinicians, and patients.
In another viewpoint, attorney Susanna Baruch and colleagues caution that physicians may be judged on compliance with restrictive legislation which may not align with evidence-based practice.
JAMA also published a research article describing a clinical decision support system for imaging requests by Dr. Dake and colleagues. The authors evaluated a support system to see whether it helped clinicians order appropriate imaging studies. This was a cluster randomized clinical trial that involved 3 German hospitals with 26 departments. 13 clusters received the clinical decision support system and 13 did not. This support system did not reduce the number of imaging requests considered inappropriate. The authors indicated that none of the participating departments chose to continue using the clinical decision support system after the study ended.
JAMA published 4 research letters as well. Dr. Jonas and colleagues included over 1 million women, aged 15 to 49 years old, from the Danish National Registers in a national cohort study evaluating contemporary hormonal contraception and venous thromboembolism, or VTE, risk. The authors assessed prescriptions for different hormonal contraception and the first diagnosis of lower limb deep VTE, or pulmonary embolism. They reported different VTE risk variation with different hormonal contraceptives and noted that combined pills containing third-generation progestins had the highest rates. In another research letter, Dr. Mullins and colleagues examined travel times for Medicare beneficiaries living in rural areas who received surgery. The authors investigated whether the percentage of rural patients' admissions with travel time more than 1 hour changed during the study period, 2010 to 2020. They report that there was a significant increase from 36.8% to 44.1%, indicating more rural patients have longer travel times for surgery.
In another research letter, Dr. Emmerich and colleagues investigated trends in obesity-related measurements. They included more than 41,000 children, adolescents, and adults who participated in the National Health and Nutrition Examination Survey, or NHANES. The authors specifically looked at the 2013 to 2014 to 2021 to 2023 survey cycles. They reported small increases in the percentage of children and adolescents with obesity and adults with severe obesity. JAMA also published a research letter by Dr. Trish and colleagues in which they reported their findings on preferred branded drug cost sharing for patients with Medicare Part D. Their data included the use of co-payments and co-insurance for preferred brand name drugs for beneficiaries with Medicare prescription drug plans and Medicare Advantage prescription drug plans. The authors concluded that Medicare prescription drug plans increasingly used co-insurance, while Medicare Advantage prescription drug plans consistently used co-payments for preferred drug brands. JAMA published several other viewpoints this week. Dr. Poe and colleagues articulate the responsibilities of different research personnel and ways to ensure progress and accountability for the use of race and ethnicity in biomedical research. And there are 2 viewpoints on the emerging Trustworthy and Responsible AI Network, or TRAIN, in the U.S. and Europe. Dr. Emby and colleagues explained that TRAIN emerged in the U.S. as a group of 50 health systems working together on AI in healthcare. In their viewpoint, Dr. Van Genderen and colleagues discussed the creation of the European TRAIN initiative, which mirrors the U.S. model. They reiterate their hope for domestic and international collaboration on healthcare AI. In a separate viewpoint, Dr. Himmelstein and colleagues explore private equity's emerging role in healthcare acquisitions.
And in a late-breaking viewpoint this week, Drs. Rochelle and Lauren Walensky write about the importance of NIH federal funding for research. They present concrete advancements that resulted from this funding, such as NIH-sponsored research by Nobel laureates and improved survival for patients with AIDS and pediatric leukemia. JAMA has a variety of clinically relevant content in the clinical review and education sections this week. There is a JAMA Insights article by Dr. Obecabtagene and colleagues. They describe the FDA review and trial results of the Obecabtagene Autoleucel for B-cell acute lymphoblastic leukemia. In a second JAMA Insights article, Dr. Chopra shares guidance for selecting different types of venous catheters for patients. He includes important considerations for a variety of clinical indications.
JAMA also published 2 patient pages this week. One page explains carbon monoxide poisoning and includes important risk reduction strategies. The other patient page covers peptic ulcer disease. JAMA also published 2 items in medical news. First, there's a JAMA data brief. This medical news article discusses differences in personal health care spending across U.S. counties and drivers of that variation. There's also a JAMA Plus AI conversation with Dr. Kanjilal from Harvard and Associate Editor Dr. Swen, in which they discuss applying machine learning to the field of infectious disease. Let's end with a clip from their conversation.
The way it is right now is once a healthcare system invests in a specific EHR, it's really hard to break them away from it because of the amount of investment needed. However, it is possible to start layering things on top of existing EHRs. In my opinion, that's not going to work. I really think you do have to build from the ground up. And so how do you break that knot is challenging. But again, I think having a strong funder, a lot of investment, and a really good team, you don't actually need that much to get an excellent product that will change minds.
Thanks for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Linda Brubaker. This episode was produced by Shelley Steffens and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in the episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.